So once again, thanks to our esteemed colleagues from Brazil. And if you notice over here, this is the flag of Brazil and Pakistan. And Brazilian flag is on top of Pakistan at this point, because they have done wonderful work in anatomy and in neuroanatomy, and really something that inspires all of us. So the anatomy of ventricles is pretty complex. Well, everything about brain is complex, but I thought that maybe instead of going into details of just anatomy, because most of us over here have a basic understanding, so I will just spend very little time on the anatomy of the ventricles, but little more in the approaches. And when it comes to approaches, I have taken help from uh, um, Cohen's uh, neurosurgical atlas, and the pictures that he has used of Al Roten, which are one of the best, amazing pictures. And I know that Eduardo also worked with Al Roten and has produced some of excellent neuroanatomical specimens. So this is the logo of PANS. This is the logo of AKU, where I'm a faculty, and here we have this collaboration. And this is not only Brazil and Pakistan, but we have speakers which will be coming from other part of the countries as well. So okay, okay, laser point. All right, there you go. All right, so so I will just go over this a little bit, just to refresh the anatomy and point out few things. So all of us know about this lateral ventricle and the atrium and the frontal horn and the occipital horn and the temporal horn. We all know about the foramen of Monro. We all know about the third ventricle and the recess in the pineal recess over here, and the infundibular recess and the suprachiasmatic recess. We all know about that. We also know about this cerebral aqueduct opening into the fourth ventricle, and that fourth ventricle eventually with the roof and the foramen of Machendi, M for middle, median, and Lushka, L for lateral, opening over here, and then going down into the spinal canal. So that we all know. The pertinent anatomy is basically when we talk about the frontal horn. So the things that you want to notice is that the caudate nucleus projects into the frontal horn, and the anterior part is taken care of with corpus callosum, and as it curves forward, it basically enwraps in it the septum pellucidum. Right attached to the septum pellucidum is the fornix, and that brings the anterior border of the foramen of Monro. So this is pretty much well known. What we tend to forget many times, that right near the foramen of Monro, right inferior, posterior to that point, is the genu of the internal capsule. And this genu of internal capsule, we can damage it if we are retracting it many times. Then we approach it through here and we're going to the foramen of Monro. We put a retractor over here, although we put a patty and things like that, but still we can damage things over here. So be aware of that. Further, as we go down, go behind, we see the thalamus over here, and then we see part of the thalamus also into the third ventricle. The other thing that you want to realize is that the spleen, the posterior forceps, the forceps major, that makes the medial aspect of this atrium and the posterior horn. And in this, there are two bulges that one can see. One is because of the calcarine sulcus, and we call it calcar avis, and the other one is because of the collateral sulcus, and that bulge can also be seen over there. On the lateral side, the caudate tail is going right next to the atrium, and then the decussating fibers over there, they make the tapetum. So in this are also the optic radiations and some of the posterior part of the corpus callosum. The splenial fibers are in there as well. But this part gets starts to get closer to the surface, and that may be a trajectory one can decide for approaching it. Then the other things that you want to remember is just this simple anatomy, which is pretty basic, that once you have this anatomy in your mind about this caudate, about this lenticular nucleus, and about the thalamus and the internal capsule, these three things, if you remember the image of that in your brain, you can orient yourself very easily. And obviously lateral to the lenticular nucleus is the external capsule and the claustrum, and the extreme capsule and insula and things like that. So that's just a little review over here. And in a coronal section, what we see, again a review, the corpus callosum is going over here, and the septum pellucidum, and the lateral ventricles, the caudate nucleus projects into the lateral ventricle. The fornix is coming down, and we see the lenticular nucleus over here. And then a lot of time in the sections, you can have a third ventricle as well as the intrapeduncular cistern show up in here, but be careful about that. Sometimes it looks like as if it's part of the some ventricle, but that's the intrapeduncular cistern that shows up. In this section, notice how close the lateral ventricles temporal horns are getting to the midbrain, and obviously all the thalamus striates coming from here. And this is the area where the hippocampus and the fimbrium fornix, which we will see in a later diagrams. So this dissection, this is just a diagram though, but this shows gives a good concept of how the choroid plexus and the choroid fissure of the lateral ventricle turns around like this thing, like a C. And the internal capsule is like as if somebody's holding a bunch of flowers in your hand. So for the left cerebral hemisphere, think about the right hand, and the bunch of flowers are going, bouquets going through the air. That's the internal capsule. That's how it's going like this. The temporal horn is going lateral, and the frontal horn and the body is going medial. And for the right lateral ventricle, you can think of somebody holding a bouquet in the left hand. The thalamus striate vein that we will talk about further, it shows up in here. To that, so the right here is the thalamus. This is the caudate head, and then the caudate is going back over there, and in between is the thalamus striate vein. That is an important structure when it comes to the foramen of Monro. Now, to understand some of this anatomy, one obviously has to understand. Mustafa, you may like to mute yourself. So we all know about these vesicles as neural tube is formed, and the prosencephalon and the midbrain and the hindbrain. Of these three vesicles of the neural tube, the midbrain makes the smallest structure, and then prosencephalon, which creates the pons and the medulla, and then the cerebellum arises from the rhombic lip of that. So this is where the midbrain is, where in the development of the brain, there's a twist over there, and that's where the contralateral parts start to appear, and that's why the most of the structures over here in the below the midbrain, they are ipsilateral. Now the cavity that is being formed in this mesencephalon, that will end up as a cerebral aqueduct. Now this prosencephalon, it's going to produce two further divisions. One is diencephalon, which will end up producing the thalamus and the hypothalamus, and obviously the optic vesicles will come out of it, and then the forebrain, the cerebrum. Now these cerebral vesicles, the telencephalon, if you notice this, how they are curving backwards. So with this, they will take the cavity back like this. It goes. That's how the lateral ventricle starts to form there. And this structure is important to remember, that how it's forming, because it will help you understand a significant part of anatomy. If we understand that, it will help us in our approaches, understanding and avoiding the complications. And that is basically the cavum velum intrapositum over here. Now the cavum, the septum pellucidum and the cavity between them, between it, cavum septum pellucidum, that usually stops over here, because the fornix attaches to the under part of the corpus callosum, and it curves like that. Sometimes it extends back over there, and it's also called cavum vergi. It's like in a small percentage, maybe 20-30% of people, you will have that. And there's some suggestion that that may be related to some kind of neurological abnormalities, although it has not been proven. But this velum intrapositum, that is an important thing to remember, because remember how from the outpouching of these telencephalic vesicles, it started to come up from here, and then it started to grow and grow and grow and grow like this. And as it grew, it brought with it the corpus callosum, which, by the way, is only present in the mammalian and only in the placental mammalian. All the other mammalian and all other animals, they only depend on the anterior commissure. So this is something new phylogenetically. So as the corpus callosum comes up over here, there is a potential space that is on the top of this third ventricle, and as it comes over it, it makes this velum like a parda, and it's a space in there, a potential space, but it's more than potential space. It has got internal cerebral veins and things like that in there. So if you understand this part of the anatomy, then you can understand this very well, that in that velum intrapositum, you have those vessels, the choroidal vessels come to this choroid plexus, and along with it, the supply also applies to the choroid plexus for the lateral ventricle, which then curves down, and then part of it comes from the anterior choroidal artery, comes from the posterior choroidal artery. So understand this concept over here, and how the fornix, which is lateral, and it's joining together like this and then coming up. So there's a space in between the two fornices as they're coming up, and below is this roof of the third ventricle, and then going down into the pineal gland. This investment of the tissue, arachnoid tissue and other connective tissue in there with the veins is a space that needs to be understood and respected. So as the fornix comes down, obviously the septum pellucidum is in front of it, and if this space is little more potential, sometimes it can be cavum vergi, as I showed previously, and these two can not always can communicate also. So far clear on that one, right? Okay, so look at this picture again. You can see that how the internal cerebral vein is actually traveling in that cavity, in that cistern, in that velum intrapositum, and how it's coming out. As it comes out, it's below the splenium of the corpus callosum, and it's medial to the fornix, which are going to join together and be on top of that. So this venous anatomy over here is very important if we when we are approaching the ventricles. And so we all know about the suprasagittal sinus and inferior sagittal sinus, and we know about the straight sinus and transverse and the sigmoid and all that, and cavernous sinus. The internal cerebral veins, there are something that students and residents don't remember so very well. So try to focus on that one to understand that. And the two internal cerebral veins, they run in parallel, which and they are formed mainly by the thalamus striate vein. And this hairpin loop that you see over here, sort of hairpin loop, that is at the posterior margin of the choroid of the foramen of Monroe, and is covered by the plexus. And is there a reason why we have so many? Uh, who's controlling this today? Can we mute everyone, please? Thank you. Okay. So this gives a little oblique view from the posterior end of those they muted me also. Acha. Okay, so so if you look over here, the two internal cerebral veins, this is in the velum interpositum, and they come together and they join. Now and they are joined. So the vein of Galen is formed by these four veins: two internal cerebral vein and two basal vein of Rosenthal coming over here. The basal vein of Rosenthal, obviously, goes medial to the medial to the temporal lobe, and then curves around the brain stem to join the two internal cerebral veins. And this vein of Galen then is joined by the inferior sagittal sinus over here, which then makes the straight sinus. So this junction is very important, and it's right next to the pineal gland, which is at the posterior superior end of the third ventricle, and approaching it from the supratentorial edge is becomes a little precarious, and one has to be very careful about the anatomy. Approaching it below the tent is relatively better, but then the distance can be too much. So now this internal cerebral vein, it is formed mainly by the thalamus striate vein, as it's coming over here. If you notice this one, right? And this one is joined with the septal vein, and before it joins, it is also joined by the caudate veins, and this is right where it crosses into the third ventricle, and the choroid plexus crosses on top of it, which we see over here, and we see in some other pictures also. So when we talk about the third ventricle and the lateral ventricle, the approaches to the third ventricle is what helps us understand the anatomy much better, and that's because lateral ventricular approach, yes, it's important, but the third ventricular approach is important to understand. Now, the most common that we will see in our practice is something that can be approached by the either we go the transcallosal or transcarticular, and then approach it through the foramen of Monroe, or maybe through the choroidal fissure. So we can do it anteriorly or posteriorly. These are the two main ones. Occasionally you will have a tumor over here, which can be approached better if it's bulging out. It can be approached better through the lamina terminalis. And now with the endoscopic approach, this approach is becoming more pertinent, but otherwise the anterior transcortical, transventricular, or anterior transcallosal approach would have sufficed. And obviously the pineal area approach, all of us know about, supracerebellar infratentorial, and the precerebellar vein is the only problem over here, which usually you cut off. In the supratentorial approach, you come across the vein of Galen, and that's the problem. But then depending on where the tumor is projecting, you have to think about it if you can reach to that angle or not. So the most common thing that we see in the ventricular approaches are these ones. This is a diagram from some other work, but here we see over here that as we enter into the ventricle, and this is, and so how can we know whether it is a left or a right? So how many people are there? There are 60 participants. Hassan, should we ask questions at this point or not? What do you say, Hassan?
Yes, sir. I think, sir, you can continue with the talk at the end. If you want, you can ask some questions from the audience.
So those who are listening and residents and students. So I would ask them. I will give them 10 seconds to think about: is it left or right, and why are you saying it left or right? Okay. So 10 seconds have passed. So, the thing that orients you once you enter the ventricle, because sometimes, you can enter on the opposite side also, right? If you are approaching through the Cocker's point, you may little go too medially and end up on the opposite side. How do you know that you're in the right ventricle? So this is from the left side, and the choroid plexus always orients you. And with the choroid plexus, you see this septal veins over here. So if you see the septal vein over here, this is how I orient myself. Then I know that, if the septal vein is on the right side, then I'm in the left ventricle. And if the septal vein is on the left side, I'm in the right ventricle. Now once I know this point, then I start to see, okay, this is a corpus callosum which was slight damaged over here. With the endoscope, you see little blood in there. And this vein is coming from this part. And I don't show this vein over here so very well, but actually it's visible much better in this diagram. And this is the choroid plexus over here. And we see the thalamus striate vein coming over here. And then the septal vein is coming from here. In this picture, actually, you see it better over here, right? Okay. So as we go through the foramen of Monro, you start to see the two mammillary bodies, and then this is the area where you want to do the ETV. And obviously, if you peek back over here, it will be opening of the cerebral aqueduct over here. Okay. So these are the pictures from Godel Cohen's Neurosurgical Atlas, and these images are all done by Al Roten and Professor Eduardo Ribas has also worked with him. So this one, if you look at the anatomy over here, these are shown as in different serial steps, basically. So whether it's transcortical, transventricular, or transcallosal, it doesn't matter. You're going to come to the foramen of Monro to orient yourself. So once you come over here, you can see the foramen of Monro over here. You can see the thalamus striate vein and the caudate vein joining that, and you can see the choroid plexus over here. The choroid plexus will have some venous anatomy and some vessels, arterial vessels in there also, which you can distinguish easily. And if you're approaching from the right side, you will see on the left the septal vein, and if you're approaching from the left side, you will see the septal veins on the right side, and that will orient you basically to this which side you are on. Over here, if you look closely, you can see the choroid plexus, which is different. This is cadaveric sample, otherwise it's much more pink over here, and it crosses over here and then curves inside. It shows mass centromedia, which is not present in all humans, all brains. I think maybe a quarter or 1/3 may not have this at all. There's not an important structure anyway. And further dissection in this picture shows the choroidal vessels, branches coming over here, and you see that how the thalamus striate vein ends up as the internal cerebral vein when it's joined by the septal vein, and it's curving right at the mouth of the foramen of Monro. Looking at this picture, this is a cadaveric sample. I would never retract the fornix this much. Obviously, if you do it, you want to put a patty and just a slight retraction, and only retract it for short periods of time and remove the retractor. Dynamic retraction is always better. If you leave your patties in there, you retract a little bit, and then you remove those metal retractors. The patties, they themselves, try to retract something, and then when you put some suction and bipolar on it, you can retract it a little more, and that becomes a dynamic retraction. So, so retracting the fornix over here, from the roof, Al Rotten's dissection, where we see the third ventricle, the body of fornix is coming together, the massa intermedia, and that's the infundibular recess over there. And over here is the, if you see over here, aqueduct over here, and the posterior commissure, and obviously splenium is over back over here. So I hope this is clear enough to us. Actually, I should have put this picture first. This is the transcallosal approach that, again, from the Aaron Cohen Godel's atlas. And here, you see the fox over here and it retracting. I mean, I personally, I don't know for what reason, I don't like the interhemispheric approach. And the reason is because of these veins that they come in this, and I don't want to mess with these veins. I would rather make a very small, very small retractor, and if it's on the right side, just go transcortical, transventricular, and it just gives me anatomy works very well. But if you are approaching it as the intrahemispheric, then obviously you have to be careful about the pericallosal and callosal marginal vessels, and that's where we run into a lot of problems also when they start to bleed. But if you are able to retract it, which can be done in a very nice way, because there's not a lot of adhesions over here, rycnoid, then the corpus callosum is right there, and a small hole in the corpus callosum away from, if you can, the interparietal region. If you can avoid it, then it will be better, because in the interparietal region there's important connection. It has been shown that the interparietal connection of corpus callosum is more important for intelligence and other things. Okay, so whether you get to this lateral ventricle through the intrahemispheric approach, or you get to the transventricular, transcortical transventricular approach, you will get to this. You will see the thalamus striate vein between the caudate and the thalamus, and you will see this choroid plexus, and the choroid plexus always orients you. And you obviously never see the fornix so nicely, but then you have to imagine that this is where the fornix is. If you notice, the fornix, you don't see it so nicely. You don't see it so nicely, but this is where the fornix is. So keep that in mind, that right next to it is the fornix. Now the approach to the third ventricle, if you want to go through the foramen of Monro, if it's big enough, that's good. Otherwise, you can go through the tinea choroidi and basically go medial to it, and the connection between the choroid plexus and the tinea choroidi, this is called the tinea fornicis, which is on the medial side. Go through that, and that will lead you into the third ventricle. But that obviously goes through a little part of the velum interpositum as well, because the velum interpositum is where the internal cerebral veins are. But then once you're in there, this avoids the risk of, if you want to go through the foramen of Monro, you can damage the connection between the thalamus striate vein, and if it starts to bleed, a thalamus striate vein and the internal cerebral vein, if it starts to bleed, it bleeds a lot. Some people talk about that, damaging this vein is not of much consequence. My personal experience that this can be devastating also. So this I think is an important vein, and I don't want to mess with this too much. So until and unless I have a good opening over here, I would rather move back a little bit over here and go through the tinea fornicis. If it's obviously something like colloid cyst, this is again from Aaron Cohen-Godel's Neurological Atlas. It's bulging through the foramen of Monroe. You can evacuate the content over here and remove it. You don't really have to dissect the tinea to look into that, but if you do, this shows nicely the picture, the two intercerebral veins and the space in between the third ventricle. That was more of the anterior half of the lateral ventricles. When it comes to the posterior half of lateral ventricles, then some of these things are important to remember. That in the posterior half, you will be going through the splenium. You will be right next to the pulvinar, the choroid plexus, and this is a nice picture to see. See this is the lateral view. Well, this is the lateral over here, this is medial over here, and this is the top and this is the side. So this is the foramen of Monroe. This is the septal vein coming and joining the thalamus striate vein. You can see the lenticular nucleus, which has been cut. Otherwise, it would have been this big like this. The caudate head is over here. And the internal capsule is going like this. And obviously, as internal capsules, the genu is always next to the foramen of Monroe. So this choroid plexus over here curves around, and you can see that how the internal capsule goes in between and goes medially. So obviously, once you open up from the atrium, the occipital horn, and you go into the temporal horn, you can see the hippocampus very well. And this is that bulge over here, the calcar avis, which also helps you orient. Once you're here, you will not see any choroid plexus because it's all going around like a C. Here you will have things without choroid plexus. This anatomy we have already seen a few times now. Thalamus striate vein going in, joining the internal cerebral vein, and then the septal vein. The venous structures in the choroid plexus, the choroidal veins and things like that can be visible, can sometimes not be so visible. Okay. So this is pretty much the same picture over here. You see how the genu is so close over here. This nice picture shows over here the internal capsule. This is the septum pellucidum. You can see over here. This is the atrium over here. So this is the left atrium. The tapetum is over here, and you notice that how the lateral ventricular veins are coming in, and the choroid plexus is curving like a C over here. And notice the choroidal vessels, the posterior choroidal vessels are in there, and they can supply the choroid plexus or the meningioma and things like that. And this calcar avis, it helps you orient. Over here, for some reason, you don't see a lot of distance, but there's a little more thickness over here from the calcarine sulcus. And the pulvinar is also something that you want to keep in mind, how it's curving around, and the pulvinar is projecting back to you, because at your resecting tumor, you are right next to it. Okay, so one of the approaches is the transcallosal approach. I don't have my own picture of transcallosal approach, so I just took it from the net, and I forgot to give credit to who it was. Anyway, okay, so the transcallosal approach is one can use the transcallosal approach, not callosal, translaminar terminalis approach. One can use a translaminar terminalis approach either using the endoscope, going through this. I have, I'm not an expert of this, but then endoscopically, you can approach it just above the chiasm. And if you notice over here, this is where the chiasm is. You can see the infundibulum. You can see the pituitary stalk over here, and this is pretty thin veil over here. And if the tumor is big enough, it's going to be bulging out from here. And resecting, making a hole over here is pretty safe as long as you remember that the anterior communicating artery is right above it, and too much retraction to look into that, if you're not using the endoscopic approach, can damage this connection of A1 and A2. Sometimes there are vessels that are going down from here also, but usually the supply to the optic chiasm is coming from below. So this is a reasonably safe area. And in this dissection, this is again Al Rorton's dissection, I think, yes. you can see that once you have the lamina terminalis open, you can see all the way to the cerebral opening of the cerebral aqueduct. Here is the optic chiasm, and infundibular recess is right over here. This is the suprachiasmatic recess. Infundibular recess is not visible; it's hidden by the chiasm, and the aqueduct is over here. This is the floor of the third ventricle, and the mammillary bodies over here. This is an endoscopic picture, and I forgot to put the reference of that paper. So you can see that how the opening a hole in lamina terminalis and some of the vessels which are supplying this area can be stretched. So one has to be careful about that. And looking where the tumor is, dividing into 4 parts, and these parts are very difficult to approach from here, the part 3, but a part 4 can be approachable, and part 2 and some part of part 1 as well. So I just wanted to show some examples. We have only 10 minutes left. So this is 25-year-old right-handed female, referred to the neurosurgery clinic after his CT scan, after routine follow-up. So there was a CT which was done after routine follow-up for mastoidectomy, which showed intracranial lesion. So if you look at this lesion, I want you to think about, this looks like a meningioma. We're not sure though. But then you see this very important vessel over here, which is feeding it. And that's coming from the choroidal vessels over here. But it's also being fed by the medial posterior choroidal vessels as well. And this supply, if you want to do angioembolization, it's not easy to embolize this. So obviously, surgically, you have to get to these points first, and then remove the tumor. So approaches in this, since I don't know if I can ask questions or not, the approaches in this, one can think of a transcallosal approach, one can think of transcortical, transventricular approach, and so in this case, we ended up doing the transcortical, transventricular approach, and I use this since it was right side, and I use high parietal approach. I don't go lateral, not like the Keynes point. I go through the above the interparietal sulcus if I can, to get to this and get the choroidal vessels on this one. And so she did fine postoperatively also. This was a gentleman, that 39-year-old gentleman, right-handed, presented with gait disturbance. Now it looks like as if it is in the both ventricles on the first look. That's what it looks like, right? And one would think about approaching it through the transcortical, transventricular approach. In this case, one can approach it from the left side also, if you did not have this part projecting up here. But since this part is projecting into the frontal horn, if you approach it from the left side, obviously from superior frontal gyrus or superior frontal sulcus, you end up missing this part. So it's best to approach it from the side where you can see it face on. And actually, in this case, it's not in the both ventricles. It has pushed the septum pellucidum, and here is this indication. If you notice over here, this tells you that septum pellucidum has been pushed and over to the other side. So this thing was actually all on the one side of the ventricle. And we have, here we go. And in this, if you notice that how removing this from this side left the septum pellucidum intact. So it was not, it was attached a little bit to septum pellucidum, but it came out very well. So I think, this point where the septum pellucidum attaches to the corpus callosum, you could see over here, and that helps you decide whether you are going to approach. And even if you have to do it on the side, you can go through septum pellucidum. Now, sometimes the tumors can arise from different regions and project into the third ventricle and project through the third ventricle to the foramen of Monro. This was one of those cases, a 6-year-old child which turned out to be pilocytic astrocytoma, huge mass, and I decided to approach it through the ventricles, through the foramen of Monro approach, going from the left side, and we were able to resect all of it without any significant deficit. The kid is doing fine, but the problem in this case was obviously approaching it from any other angle would have been difficult because of this projection up there, and I did not know pre-hand that how stuck it would be to those ventricular walls. So this worked out very well over there. So now we so those were the approaches for the tumors and pathologies in the projecting into the lateral ventricles and into the third ventricle somewhat. Now for pathologies projecting into the temporal horn, that was the body and the lateral and the frontal horn of lateral ventricle. If pathologies are projecting into the temporal horn, you need to obviously understand the anatomy very well, and Dr. Eduardo Ribas has talked about this in detail, but just to revise a little bit more of anatomy over here. So you see, this is a section, you see the part of the midbrain over here. The cranial nerve is starting from the interpeduncular cistern. This is the left temporal horn, and this is the head of the hippocampus, end of hippocampus, and the uncus is going over here. And as I've told in the past, within the uncus is the amygdala, and so amygdala is right over here inside. So approaching, if you do a selective amygdala hippocampectomy, we approach it. I usually approach it from the middle temporal gyrus. But then once you get to here to the hippocampus, the anatomy is pretty clear. The this is where the amygdala, you can see the amygdala over here, and in this temporal horn again you can see the amygdala projecting over here clearly there. So uncus sort of curves around it like a hook around it. Okay, in the next picture is what is a diagrammatic picture. So once you come through this through the middle temporal gyrus, it leads you directly into the temporal horn, and once you're in the temporal horn, this shiny surface of the hippocampus guides you very well. And looking a little bit up, if you see the choroid plexus, you know that you are in the right place, right next to the choroidal fissure. And then, you know, the collateral eminence, because of the collateral sulcus, gives you an idea that how extensive, how far you have to go for the hippocampal resection. And in selective hippocampectomy, you can just start dissecting from here, and then try to peel it off as a one piece if you can. So that's good from that anatomy. Okay, so now here's another example. This is another this is in the trigone, this tumor, and you know, it's not enhancing a whole lot. So initially it would look like maybe it's in a trigone, so probably meningioma kind of a tumor, right? It turned out to be a choroid plexus papilloma. But the question is, how would you want to approach it? So obviously, if this was projecting a little bit up here, I would have gone, you know, high parietal approach, transcortical, transventricular. But notice this, it's, you know, almost up over here, right? It's the posterior part of the temporal lobe. You know, it's right over here. And this gave me a very good access to it. And I don't have that picture where it was accessed through there, but anyway, we accessed it through here, and it turned out to be choroid plexus papilloma and came out nicely. Here is another one, which was a glioblastoma, and it did not look like glioblastoma to begin with, some cystic tumor. In this case, In this case, so going through this approach would have been a little difficult because it's too far medially, and that gives me more anatomical view, looking both anteriorly and into the trigone and in the beginning part of the temporal horn. So this one I approached from the right parietal incision, and here's the it was approached from here basically. There was a little residual. So once you enter the ventricular cavity, you see a mass tumor. You can start to debulk it. So, but the idea is, as you debulk it, you want to get to the edges of that, because whether it's a fourth ventricle or whether it's a lateral ventricle, once you get to the edges of that, you see the smooth surface of the ventricular wall. That then gives you an idea of how extensive the tumor is, what is the limit of that tumor, and then you can get to the stump of the tumor. So I always, before I may debulk it a little bit, but I want to go beyond the tumor to see the surface, and then go from there and approach it. This way I know that what normal structures I may encounter, and that is particularly true in the fourth ventricle. Now this is an interesting case we did, I think 2 days ago. So this is a pineal gland lesion, right? Could have approached. I mean, if you look at it, the distance is not too much over here, right? So, but then we did not know. So the first time when you see a lesion like this with the hydrocephalus, it's best to actually go inside, do an ETV, and get a biopsy. That's always best to do it like that. We did that. The biopsy turned out to be grade 2 or grade 3, something in between, penocytoma, a pineal parenchymal tumor. So, so we went back in. Now, going back in could have gone from here. And I think, it's not advisable to go from the same route for ETV because it is so far back in there. But since I was there already and I knew that it was very approachable from that, because sometimes the anatomy of the head and how far things are extending back gives an idea. But I had seen it before when I was getting a biopsy. I decided to approach it from the same route because I also wanted to look at if the ETV was working or not. There were some issues. She was having some hydrocephalus. So we went through the same approach and we went transforaminal. Now in this, I had decided that if it's a problem, I will go medial to the choroidal plexus and then approach it. But then, as we approached it from the foramen, we were able to get to the tumor completely. This is gel foramen and Surgicel over here. Not much tumor left inside, near total resection. But then the approach worked very well even through this. Although I would not suggest that this is something that should be tried on a regular basis. But since I had seen this before, I knew the thalamus-striate vein and cerebral vein connection junction was easily, we could go beyond that. And if I found that it would be difficult, I would divide it through the choroid fissure. This is the post-op image CT scan with the ventriculostomy with the EVD in here, so why do we have this picture? Right. Okay. So yeah. So this is this is the previous ETV. These things. I don't know. We have sent these samples. I've never seen this thing. This debris wasn't there like this, like crystalline structure. So we have sent it out for study, for looking at it. But anyway, this was removed. We were able to see the patency of the ETV, and if you look at this one, going through here, right? So this is after resection. So anteriorly over here would be the previous ETV, and as we look back, this is the cerebral aqueduct, and this is where the tumor was. We could see actually the roof of the third ventricle also. What happened here? Okay, why is it not running fully? I don't know. Okay, And up there is the was that foramen of Monroe, choroid plexus. You could see that thalamus striate vein. Now this problem, I think this video is not running fully, but but that hole over there that we see in the end, that hole over there was the cerebral aqueduct. And if you look at the image over here, it shows. So we could see the ETV also, and we could see all the way up until over here, and the cerebral aqueduct was visible over here. Okay, so last one is the telovelar approach, and just quickly, that's the a known approach for fourth ventricular tumor. Key points is basically as you open it up from posteriorly, you see the tonsils herniating, and remember, you will always see the pica loops coming down. And the key things in this is that if it's something is stuck to the floor of the fourth ventricle, you want to avoid dissecting aggressively. Again, go beyond the tumor and figure out where the floor of the fourth ventricle is, and then remove things away from it instead of staying within the tumor and debulking it, and then you don't know where you are. It's not unusual to see the opening of the cerebral ventricle. These are the pica vessels looping below over here. Here is another of Roton's images where it shows the middle cerebral peduncle and the foramen of Luschka over here. The choroid plexus going to the foramen of Luschka, and this is the roof of the fourth ventricle. This is the pica loop going back over there. And here is a case where 11-year-old boy, 1 year history. So attached to the floor of the fourth ventricle. Now, many times it's not attached; it's attached to the roof. Things like ependymoma and things like that. And it comes off so nicely. But in this case, unfortunately, it's attached to the floor of the fourth ventricle. But again, using that technique or that strategy of going and then looking at the floor and then coming from the floor and then shaving it off from there instead of dissecting it, so shaving it off from there, it worked very well. He had few days of problem with swallowing with NG tube, but otherwise remained intact, and that swallowing problem also resolved with complete good gross total resection. But the key was again looking at the sides. Now when you're in the brain stem, again avoid the dissection in the midline getting into the brain stem. Always go from the side if you have to. I mean, you want to avoid getting into brain stem for anything anyway, but if you have to, don't go in the midline, don't go where the motor nuclei of the cranial nerves are. Middle cerebral peduncle is a safer area to go into that if you need to. And I think that's it. So it's 5 p.m. and